You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions. Present your toughest ICU cases. Collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, everyone, and welcome to our Respiratory Critical Care webinar. Today, we have a very special webinar and a very critical topic we are trying to cover and try to understand how to treat our patients better and to improve their outcome, and also to improve our clinical practice, because every second counts in the respiratory ICU. Our patients with pneumonia and several infections, they don't die because of the infection, but they die because of the storm they have and because we might lose the battle. So we are trying to win the battle today in the ICU catastrophe and disaster and try to manage our critical infections in the ICU in a better way. So we have very special guest speakers today. We have Dr. Shireen Nassar, who is going to give us a case-based discussion, and she is a lecturer of chest medicine at Cairo University, Egypt. Dr. Ayush Bandi, he is a respiratory critical care consultant at MGU Group in India, and he is going to give the main lecture of managing critical infection in ICU. Our two moderators today are Professor Hibatullah Hasal, who is one of the founder of our Respiratory Critical Care Fellowship Program, and she is a professor of chest medicine at Cairo University. Dr. Alauddin Ghanem is a consultant and he is intensivist at Sheikh Shalbout Medical City in United Arab Emirates. Both are going to help to answer your questions by the end of the webinar in the QA session. Here is our humble agenda today. So after this brief intro, Dr. Ayush Bandi is going to give his first part of his talk, Managing Critical Infection, focusing on respiratory infection, life-threatening infections in ICU. Then Dr. Shirin Nassar will give about 10-minute case-based discussion. Then we'll go again to the second part, how to critically improve our patients' outcome and manage our patients in a precision way with respiratory infection by Dr. Ayush. Then again, Professor Heba and Dr. Alauddin is going to help to answer the question. So great speakers, great moderators and the panelists today. And just before we start our first presentation, I just want to let you know if you have any questions or concerns or inquiries, you can type it in the QA box. And all attendees should receive certificate of attendance by next week. If you want not only to hear the lecture, but also to read the transcription at your earliest convenience with your own language, you can enable or activate the show caption option. With that, we are not here to teach you the fact, but we are training your mind to think. We are giving you challenging information to help you to think better and to do critical thinking and brainstorming, because we either think or think. With that, I'm going to let Dr. Ayush to give his first part of his lecture. And it would be about 20 minutes, and it will be talking about mainly mechanism and the prevalence and diagnosis of critical infections in ICU.
Hello everyone, I'm Dr. Ayush Pandey and I'm a consultant in respiratory and critical care at MGU Group of Hospitals, India. I would especially like to thank Dr. Amir, President of the WICCEM USA, for allowing me to speak on the topic respiratory storm, managing critical infections and battling ICU catastrophes. So every intensivist has managed pneumonia, but what kills our patients is often not the pneumonia itself. It is the uncontrolled inflammatory cascade that follows. So when you talk about the respiratory storm, it is not just an official disease entity, but it is a clinical syndrome describing rapidly progressive respiratory infection accompanied by immune dysregulation leading to catastrophic organ failure. Now, by this lecture, we have to ask at the end of this lectures 4 or 5 important questions. The first one is, which patients is about to deteriorate? So recognizing the severe pneumonia early is much more important than simply diagnosing the pneumonia. The second question, why does the deterioration occur? The third is, how do we treat aggressively without overuse of the antibiotics? So we have to keep in mind regarding the antimicrobial stewardship. The fourth is, how do we support our failing lungs? And the fifth is, how do we prevent ICU disasters? So these are the important questions which all the answers will be clear at the end of this lectures. Now coming to our topic of respiratory storm, why should we care? Now, when you see a healthy lung and if it develops pneumonia, what happens if it has not been controlled? It progresses to hypoxemia, then finally ARDS, shock, MODS, and ultimately death. So initially, the infection is confined to the alveoli. Inflammation fills the alveoli with the exudates and gas exchange worsens. So eventually, the pneumonia now becomes sepsis. So there is vasodilatation, capillary leak, myocardial depression, leading to septic shock, and reduced tissue perfusion produces multi-organ dysfunction. Now, if you look at the data, pneumonia remains the top infectious killers with cap ICU mortality 25 to 35. Hospital acquired 20 to 30%, ventilator acquired 30 to 50%, and septic shock greater than 40%. So the patients die from respiratory failure and organ dysfunction. Now, why respiratory storm? Now, respiratory storm is basically the convergence of infection, host response, delayed management, critical illness, and each factor helps in amplification the next. So symptoms may begin with initial, maybe a viral URI, and by the time the hypoxemia develops, significant alveolar injury has already been set up place. So there is a hyperinflammatory response, there is a macrophage release, IL-6, TNF-alpha, IL-1 beta, neutrophils releases the proteases, reactive oxygen species, and eventually they are destructive. So there is a cytokine storm, the immune system becomes dysregulated, it injures the host tissues, and diffuse alveolar hemorrhage occurs. There is delayed effective therapy. If it occurs, that leads to higher inflammation and higher mortality. Even when you look at the, delayed ICU transfer, so it is one of the most common avoidable causes of death. So many patients remain on the ward despite increasing oxygen requirements. So escalating the oxygen demand predicts the ICU admission earlier than the chest X-ray findings. So respiratory infection. So pathogens reach the alveoli. Alveolar macrophages detect the bacteria. There is inflammatory cytokines release, and endothelial injury occurs. Then fluid leaks into the alveoli. There is leakage of the proteins. Pulmonary edema develops. ARDS develops. Ultimately, the patient lands up into shock. And there is inflammatory mediators that leads to vasodilatation, capillary leak, ultimately leading to hypotension and MODS. So why ICU patient develops respiratory infections? There can be various factors with respect to the patient. There can be comorbidities like diabetes, COPD, CKD, hospital-related factors, MDR organisms, biofilm colonization, and ICU-related factors like intubation. The patient is on ventilator, sedation, tube feeding, and use of the central lines and urinary catheters. Now, if you understand the basic differentiation between the two terms, colonization versus infection. So colonization means that the organisms are present without tissue invasion, whereas infection means that microbial invasion is there with the host inflammatory response. So usually the colonization is not treated, but if the patient is there with fever, purulent secretions, near infiltrates, your culture reports are positive, that suggests the patient is infection. So treating the colonization is one of the biggest causes of antibiotic misuse. Now, from biofilm to the pneumonia to the ARDS, now there is microaspiration that occurs around the patient on ventilator with a ET tube cuff in place. So bacteria are there is a biofilm develops. So biofilm protects the bacteria from antibiotics. They enter the distal airways, leads to pneumonia formation. There is inflammation, ARDS and shock. So biofilms can make the organism 100 to 1000 times more tolerant to the antimicrobials than free-floating bacteria. Now, cytokine storm and in immunothrombosis. So pathogen activates the alveolar macrophages. Macrophage release the cytokines IL-6, TNF-alpha, IL-1 beta. This activates the vascular endothelium, which becomes leaky. Platelet and coagulation pathways are activated, leading to microthrombi into the pulmonary circulations. And this is called as immunothrombosis, which is a protective mechanism that becomes harmful when it becomes excessive. So there are various laboratory markers also that increases CRP, ferritin, D-dimer, LDH, and decrease in lymphocytes, lymphopenia that can indicate immune dysregulation. So now the question here arises is, can a patient with severe cytokine storm even when the bacterial load is already falling? So yes, definitely the host response may continue despite decreasing the pathogen burden. So that's why recognizing this process early is essential, because the first few hours of the ICU management determines the patient's trajectory. Now, ICU approach to the respiratory storm. Always remember the 5 golden principles. Recognize early, recognize the oxygen requirement, recognize the altered mental status, recognize the lactate levels, secure A, B, C, D, E. We have been always discussing about the airway securing, breathing, circulation, disability and exposure, maintenance of the oxygenation with the use of the oxygen delivery devices. Obtain cultures before antibiotics, very important if feasible, and start start antibiotics early, because always we have to remember the golden hour in the septic shock. And the source control, for example, if there is an empyema, you have to drain it, remove infected central venous catheter. And if the patient requires ventilator support, yes, induce lung protective ventilation and anticipate shock with stewardship. So reassess antibiotics if you have started. Reassessment should be done with reviewing of the cultures, narrow down the therapy and stop unnecessary agents. And ultimately recovery, so early mobilization with nutrition, prevention of the ICU acquired weakness and planning of the rehabilitation. Now always remember the ICU respiratory microbiology. I always say that you should know your enemy. The better you know your enemy, the better you have options to fight against them. So there are a list of gram positive, gram negative, you have viruses, you have a lot of fungi, and this list is being there from to Pseudomonas aeruginosa to Streptococcus pneumoniae, influenza, Aspergillus, mucor, and Candida. Now there are escape pathogens. Now these are called as ICU superbugs. Now these organisms escape the effects of our antibiotics, in which they were grouped under the mnemonic escape. So E stands for Enterococcus faecium, S is Staphylococcus aureus, K is Klebsiella pneumoniae, A is Acinetobacter baumannii, P is Pseudomonas aeruginosa, and E is Enterobacter species. So what are the risk factors? A patient having a ICU stay of greater than 5 days, previous use of the antibiotics, patient on ventilator, previous history of colonization, there are multiple invasive devices, and the patient is immunocompromised. So the longer the patient stays in the ICU, the more resistant the flora become. Now biofilm is always the hidden enemy. Now biofilm is a community of microorganisms that is surrounded by a protective extracellular matrix, just like a bacterial city protected by a concrete wall. So antibiotics penetrate poorly, and immune cells also struggle to eliminate the bacteria. Now where do biofilms form? You have endotracheal tubes, catheters, prosthetic devices. So it is important that you should know that what is the best treatment for maybe a device for an infected central line covered with biofilm. So the best treatment is you remove the line. Gram stain and quality, sputum quality assessment. So only good quality of the sputum is worth analyzing. So a good specimen will have many neutrophils, few epithelial cells, and a poor will have mostly saliva. So you can use a sputum quality score, that is a Bartlett criteria, and that shows neutrophils, macroscopy, squamous epithelial cells. These are the various criteria, and scores has been given accordingly. So the positive Q score indicates a good sputum pathology, whereas a 0 or a minus suggests a low sputum quality with excessive oropharyngeal contamination. Coming to the CAP. Now CAP is always, one of the leading infectious killers worldwide. 450 million cases annually, leading infectious cause of septic shock. So who are the high risk groups? Elderly, patients having comorbidities. Now why does, mortality increase dramatically? Because, the patient on mechanical ventilator, septic shock, ARDS develop. So that's why understanding the causative organisms help us to choose our empirical therapy. So you have bacteria, various from streptococcus to atypical organisms, mycoplasma, chlamydia, to viruses like influenza, SARS, RSV, and adenovirus. So pathophysiology of the CAP. Now there is microaspiration of the pathogens, there is activation of the macrophages, there is more recruitment of the neutrophils, the alveolar exudate is being involved, there is consolidation with ventilation perfusion mismatch, there is hypoxemia, and systemic inflammation sets in. So mostly healthy people aspirate during sleep. Now disease only develops when the bacterial inoculation is high, the host defense system fails, and virulent organisms invade. So what are the common symptoms? The patient can present with fever, shortness of breath, pleuritic chest pain, fatigue, chills, and Physical findings like tachycardia, crepitations, crackles on auscultation, to bronchial breath sounds, dullness on percussion. Always remember the ICU red flags. The patient is severely tachypneic, RR greater than 30, SpO2 less than 90%, altered levels of sensorium, lactate levels on the rise greater than 2, oliguria, urine output less than 0.5 ml per kg per hour, and multilobular infiltrates are present. Now, two of the good scores, curve 65, where C stands for confusion, urea greater than 7, RR greater than 30, BP less than 90 by 60, and age greater than equal to 65. So score 0 to 1, home-based treatment can be given. Score 2, needs hospital admission, and score greater than equal to 3, USS for ICU. Pneumonia severity index, on the other hand, it includes age, comorbidities, physical examination, lab results, and laboratory findings. So young patients with severe hypoxemia have deceptively low curve 65 score. Always integrate the clinical assessment. Now, it is very important. Now, based on the ATS and IDSA severe CRAP criteria, you have a major criteria. So 1 major or greater than equal to 3 minor criteria strongly supports the ICU admission. So you have these two important major criteria: septic shock requiring of the vasopressors and respiratory failure with the requirement of the ventilator, and this list of minor criteria that should include greater than equal to 3 criteria. So diagnostic evaluation, you have to send a battery of investigations from CBC, LFT, KFT. So leukocytosis, leukopenia, thrombocytopenia, DIC, or severe sepsis can be predicted. RFT, KFT assesses the organ dysfunction, calculate the severity scores. CRP and procalcitonin. CRP is a good inflammatory marker. Procalcitonin rises earlier and supports bacterial infection. ABG is, again, it tells you the oxygenation, ventilation, acid-base status, lactate levels. Now, lactate is an important marker. High lactate indicates very poor tissue perfusion and possible septic shock. Blood cultures is indicated in septic shock patients, ICU patients, patients who are immunocompromised. From sputum gram stain culture, you have viral PCR, Legionella, and pneumococcal urinary antigen. So remains positive despite the previous antibiotics. Imaging chest X-ray is the first line. Again, it will show you lobar consolidation to multilobar disease or pleural effusion. CT chest should be reserved for abscess, empyema, cavitation, non-resolving pneumonia, and fungal pneumonia. And blood cultures indicated in patients who are ICU admitted. There is a cavitatory disease formation and leukopenia or empyema with severe CAP. Now, management of severe CAP. You make the patient, if there is requirement of the oxygen, supplement the oxygen. Early administration of the antibiotics is the key. So target is to maintain between 92 to 96%. And in case if the patient is a COPD or obstructive airway disease patient, between the 88 to 92%. So sepsis screening is must, from QSOFA score to new SOFA, but SOFA remains the preferred ICU score. So what is the ATS recommended guidelines? Beta-lactam combined with macrolides or beta-lactam with respiratory fluoroquinolone, usually 5 to 7 days, but longer if there is empyema abscess. Now, if the patient is a MRSA, you can add vancomycin linezolid, and if there is pseudomonas risk, add piperacillin tazobactam or cefepime or meropenem. Now, antibiotics should be started within 1 hour in septic shock, very important, and reassessment should be done at 48 to 72 hours and de-escalate based on the culture reports. Now, this is important. This we have already discussed, so I'm not discussing much into detail with respect to this. So, hospital-acquired pneumonia and VAP. Now, hospitalization itself changes the microbiology. How do you define a HAP? Pneumonia occurring greater than equal to 48 hours after hospital admission. And VAP is greater than equal to 48 hours after intubation. So now why this is important? Because it increases, VAP increases the ventilator days. It increases the ICU cost of the patient. It increases the resistance. It increases the mortality. So it is important to identify early HAP versus late HAP and VAP based on the various organisms which is being there. Now, this is what I talked about. So intubation, again, biofilm formation, we have already discussed. The patient who is intubated, there is microaspiration, there is colonization of the bacteria, there is alveolar inflammation, and there is happen web. Now, how you diagnose and manage the happen web? There is a diagnostic criteria. So newer pulmonary infiltrate plus two of these criteria, patient having fever, pulmonary secretions, leukocytosis or hypoxemia. So infiltrates alone are unreliable, and many ICU conditions mimic pneumonia like ARDS, pulmonary edema, hemorrhage, atelectasis. Laboratory investigations, we have already talked about, and imaging modalities. There is a score which is clinical pulmonary infection score. So it includes temperature, TLC count, chest X-ray, PaO2 by FiO2 levels, culture. So a CPIS greater than 6 suggests a VAP. Now, specimen endotracheal aspirate is the first line. BAL, bronchoalveolar lavage, selected for severe and non-resolving cases, and pleural fluid if you are suspecting a underlying empyema. So CPIS should be used as an adjunct tool, not as a sole diagnostic tool. Now, never treat an X-ray. Always remember, treat the patient, because diagnosis is only half the battle. Prevention is equally important. So treatment and prevention, the patient is a low MDR risk, piperacillin, tazobactam, cefepime or levofloxacin. High MDR, 1 anti-pseudomonal beta-lactam plus MRSA coverage. Stewardship is very important. Start early if you are suspecting a septic shock. Obtain cultures before antibiotics. Review at every 48 to 72 hours and de-escalate accordingly. Now, there is a prevention bundle. Head end of the patient should be elevated to 30 to 45 degrees. That reduces the aspiration. Daily sedation interruption helps in earlier extubation. SBTs should be given. That leads to lesser ventilation. Proper oral care along with hand hygiene, subglottic drainage, that should be done to remove the secretions. Viral and fungal pneumonia, again a long list of organisms from virus. Who are the high risk patients? What are the key features and what is the specific therapy? Now, we all have seen, and COVID-19 has reminded, that viruses alone can produce catastrophic respiratory failure. So based on all this, increasing cause of the ICU admission worldwide, and what are the clinical clues? There is bilateral GGOs on the X-ray. Or on the CT chest, there is lymphopenia, low procalcitonin, viral PCR is positive, and the patient rapidly deteriorates. So early multiplex respiratory PCR, lung protective ventilation strategies, use of the corticosteroids only when it is indicated, and early ECMO referral should be done in refractory ARDS. Now, think early, diagnose early. Now, always go for the ABCDE assessment. And again, always, when you should suspect the fungal pneumonia, the patient is on a prolonged corticosteroid therapy, the patient is immunocompromised, there is organ transplant which has done in the patient, persistent fever even with the use of the antibiotics. So diagnostic approach, you can use the bronchoscopy with bronchoalveolar lavage, fungal culture, galactomannan, beta-D-glucan, and CT chest and fungal PCR in.
Now we are done with the first part of the presentation of Dr. Ayush. Thank you so much for this comprehensive updated presentation on respiratory tract infection, hospital-acquired pneumonias. And now we are going to take a small break with a small exciting questions, case presentations from Dr. Shireen Nassar, lecturer of chest diseases, Cairo University.
Good evening, everyone. This is Dr. Shireen Nassar, lecturer of chest diseases, Cairo University, Egypt. And today I'll be presenting a case-based discussion on respiratory critical infections. Our case is for a 67-year-old man who's admitted to the ICU with pancreatitis. On ICU day 7, after 5 days of mechanical ventilation, he develops fever, temperature 39.1, increased purulent tracheal secretions, FiO2 requirement increased from 40% to 70%, white blood cell count 18.5, while the chest X-ray demonstrate a new right lower lung zone infiltrate. Our first question, what do you think is the most likely diagnosis? A, is it community-acquired pneumonia? B, aspiration pneumonitis? C, ventilator-associated pneumonia, or D, hospital-acquired pneumonia? Of course, the answer will be C, VAP or ventilator-associated pneumonia, as the patient has been mechanically ventilated for more than 48 hours. Our next question, what are the most frequently isolated pathogens in ventilator-associated pneumonias? Is it A, gram-positive bacteria, B, gram-negative bacteria, C, fungi, or D, viruses? Correct answer is B, gram-negative bacteria. The most common pathogens in VAP include Pseudomonas aeruginosa, Acinetobacter, Klebsiella, and the Enterobacteriaceae species. Staph aureus remains common from the gram-positive organisms, but overall gram-negative organisms predominate. Nosocomial pneumonia due to fungi such as Candida or Aspergillus occur, but are more common to occur in immunocompromised patients such as organ transplant or neutropenic patients. Also, the viral pneumonias are more common to occur in immunocompromised patients than occurring in immunocompetent individuals. Diagnosis of viral infections is made by rapid antigen testing, viral culture, or serological assays. Influenza A is probably the most common viral cause of HAP or VAP in adult patients. The gram-negative pathogens associated with the most deaths included Escherichia coli, Klebsiella pneumoniae, Acinetobacter, and Pseudomonas aeruginosa, each associated with more than 250,000 deaths in the US in 2019. Next question. We're during a seasonal outbreak, a molecular viral panel on the endotracheal aspirate of the patient returns positive for influenza A H1N1. How does this viral co-infection alter the understanding of his severe pneumonia? Is it A, influenza virus causes primary viral tissue damage that disrupts the mucosal barrier, increasing the risk and severity of secondary bacterial superinfections like Staphylococcus aureus? Or B, detection of the influenza A allows for the immediate discontinuation of all empiric antibacterial therapies? Or C, corticosteroids should be immediately escalated to high doses as they improve outcomes? Or D, antiviral therapy with oseltamivir provides no clinical benefit if started more than 48 hours after the onset of the critical illness? Correct answer is A. Influenza virus causes primary viral tissue damage that disrupts the mucosal barrier, increasing the risk and severity of secondary bacterial superinfections like Staph aureus. As we mentioned, it damages the respiratory epithelium, leading to secondary bacterial pneumonia, especially due to Staph aureus and strep pneumonia. A positive influenza PCR does not rule out bacterial co-infection. Empiric antibiotics should be continued until bacterial infection is reasonably excluded. Routine corticosteroids are not recommended for influenza pneumonia itself because they may increase mortality and secondary infections. However, using corticosteroids for other indications is accepted, such as in refractory septic shock or in septic shock. Oseltamivir should be initiated in all hospitalized or critically ill patients with suspected or confirmed influenza, even if symptom onset was more than 48 hours earlier, as delayed treatment may still improve outcomes. Our next question. Which of the following statements regarding the use of serum procalcitonin is or are correct according to the American Thoracic Society, Infectious Diseases Society of America guidelines? Is it A, empiric antibiotics should be withheld until the serum procalcitonin result is available? Or B, serial procalcitonin measurements are mainly useful to support antibiotic de-escalation or discontinuation in clinically improving patients? C, clinical criteria alone are preferred over the clinical criteria combined with procalcitonin when deciding whether to initiate empiric antibiotics? Or is it A and B or B and C? Correct answer is B and C. Serial procalcitonin measurements are mainly useful to support antibiotic de-escalation or discontinuation in clinically improving patients. Also, clinical criteria alone are preferred over clinical criteria combined with procalcitonin when deciding whether to initiate empiric antibiotics. According to the ITSA guidelines, using clinical criteria alone rather than using serum procalcitonin plus clinical criteria to decide whether or not to initiate antibiotic therapy. This had strong recommendations. Also, for patients with HAP or VAP, we suggest using procalcitonin levels plus clinical criteria to guide the discontinuation of antibiotic therapy rather than clinical criteria alone. Question 5. After reviewing empirical antibiotic therapy for VAP, microbiology laboratory reports that the local prevalence of methicillin-resistant Staphylococcus aureus among VAP isolates is less than 5%. Which of the following best reflects current guideline recommendations? Is it A, empirical MRSA coverage should be included in all patients with suspected VAP? B, the decision to include empirical MRSA coverage should consider local prevalence of MRSA more than 10 to 20% and individual patient risk factors. Or C, vancomycin should always be replaced by linezolid. D, MRSA coverage should only be added after culture confirmation. Correct answer is B. The decision to include empirical MRSA coverage should consider the local prevalence of MRSA being more than 20% and individual patient risk factors, including IV drug user patients or chronic kidney disease patients on hemodialysis, or the usage of IV antibiotics in the past 90 days, among other indications. Although MRSA may account for more than 20% of VAP pathogens in some settings, guidelines recommend considering local unit prevalence and individual patient risk factors before routinely including empirical MRSA coverage. Next question. 12 hours after starting targeted antimicrobials for VAP, the patient's mean arterial pressure dropped to 52 millimeter mercury despite an initial 30 millimeter per kg crystalloid fluid bolus. His central venous oxygen saturation is 58%. Arterial lactate has risen to 4.2 millimole per liter with a collapsing inferior vena cava. Which of the following represents the most appropriate next step according to the Surviving Sepsis Campaign guidelines? Is it A, administer an immediate bolus of 5% albumin followed by a continuous infusion of dopamine to target a mean arterial pressure more than 85 millimeter mercury? B, initiate norepinephrine as the first-line vasopressor to target a mean arterial pressure more than or equal 65 millimeter mercury and add low-dose hydrocortisone if vasopressor requirements escalate. Or C, initiate an aggressive continuous infusion of epinephrine monotherapy to quickly normalize both blood pressure and the clearance of serum lactate. Or D, avoid further vasopressors and implement immediate high-volume hemofiltration to clear inflammatory cytokines from the bloodstream. Correct answer is, of course, B. According to the Surviving Sepsis Campaign guidelines, we should initiate norepinephrine as the first-line vasopressor to target a mean arterial pressure more than or equal 65 millimeter mercury. Our next question, what is the principal advantage of distal quantitative lower respiratory tract sampling in this setting? Is it A, it improves microbiological yield, allowing definite pathogen identification in nearly all patients? Or B, it better differentiates airway colonization from true lower respiratory tract infection, supporting appropriate antibiotic de-escalation? Or C, it reduces the need for the empiric broad-spectrum antibiotics while culture results are pending? Or D, it has superior sensitivity to endotracheal aspirate for diagnosing VAP and therefore should be replacing clinical assessment? Correct answer is B. The distal quantitative lower respiratory tract sampling, including BAL or mini BAL or protected specimen brush, helps differentiating airway colonization from true lower respiratory tract infection, supporting appropriate timing for antibiotic de-escalation. The major benefit is, as we mentioned, distinguishing colonization from true infection, improving the antimicrobial stewardship by allowing narrowing or discontinuation of unnecessary antibiotics. Distal quantitative sampling may improve diagnostic specificity, but it does not guarantee pathogen identification in all patients. Empiric antibiotics should not be withheld or reduced while awaiting culture results in suspected VAP. And although BAL may improve diagnostic accuracy, VAP remains a clinical diagnosis. Microbiological results complement rather than replace clinical assessment. And thank you.
Thank you so much, Shireen, for this fantastic case-based discussion. It's always good to invest on early career and mid-career physician. I always win this investment, and it's very nice. The case-based discussion, actually, it's more illustrative with bidirectional and dialogue rather than monologue. So again, when you are treating this life-threatening infection, please keep eyes on the tissue perfusion, the organ function. All the biomarkers are biomarkers of tissue perfusion and organ dysfunction. Don't wait till you will have very high biomarker, infectious biomarker. Don't wait for the procalcitonin or the lactate to go up. Please keep eyes on urine output, mental status. If the patient is getting confused, altered mental status, urine output is going down, the patient is hypoxemic. There is this term of normotensive shock. Don't wait till the patient will have, irreversible or refractory shock. You need to smell, the tissue perfusion, and when the patient will need resuscitation early on. This is going to improve our patient outcome because, eventually our patient will die not because of the infection, but because of the tissue perfusion and the organ dysfunction. With that, we are going to move to the second part of our main presentation today with Dr. Ayush and see how to improve our patient's outcome and our clinical practice and how to win the battle in the ICU.
Selected cases can be done. Advanced ICU diagnosis, which we have already discussed, ABCDE approach, and these are the initial ICU investigations that should be set. Lung ultrasound. Now, I always say that, 5 minutes with lung ultrasound can provide more information than waiting an hour for a portable chest X-ray. Now, you have to remember the various signs. A lines indicates a normal aeration, normal lung. B lines, interstitial syndrome, consolidation, pneumonia. There is dynamic air bronchograms, which is important. Pleural effusion can guide thoracocentesis. And if it is absent lung sliding, hold the ultrasound. You think of the pneumothorax. So explain the blue protocol that helps us to rapidly differentiate between pneumothorax, pulmonary edema, COPD, pulmonary embolism, and pneumonia. So it is radiation-free bedside tool used even in unstable patient, and it is a rapid diagnostic. Now, when you will order a CT chest, we have already talked about patient having empyema, cavitary lesions, non-resolving pneumonia, severe fungal infection, and diffuse infiltrates. Bronchoscopy has a both diagnostic and therapeutic role, from getting a good quality of the lavage sample to doing a TBNA cytology for fungal diagnostic. Now, if there is a mucus plug obstruction, so removing of the mucus plug, opening the lobar collapse, even in case of massive hemoptysis, and airway toileting. But always remember, when the bronchoscopy is contraindicated, your patient is hemodynamically unstable, there is raised intracranial pressure, there is severe coagulopathy in the patients, and raised ICP. Now, biomarkers, again, CRP helps us to monitor inflammation, and again, it is used for monitoring the treatment response following disease progression, but it is poor for distinguishing bacteria for viral infection. Procalcitonin, again, it is, during bacterial infection, endotoxins stimulate the PCT production. So clinical application of the procalcitonin is, it supports bacterial infection, antibiotic de-escalation, but it is not reliable in trauma, surgery, and burns. So never stop the antibiotics because PCT is low if the patient is still in the septic shock. And lactate is not a marker of infection. It is a marker of inadequate tissue perfusion. So ferritin, hyperinflammation, IL-6, cytokine storm, and D-dimer, thrombosis and inflammation. So this we have also sent battery of investigations in COVID. Now, rapid molecular diagnostics from multiplex PCR, BioFire pneumonia panel, MALDI TOF, Gene Expert MTB RF, galactomenon, that is useful in aspergillus, beta-D-glucan for invasive fungal infection. And again, MNGS. What is MNGS? Metagenomic next generation sequencing. So now it is used as an emerging technology, and it is useful when your culture reports are negative, immunocompromised patients, and even if there is unusual pathogens. But again, cost is a major challenge. So rapid diagnostics allow early targeted therapy and earlier de-escalation, reducing unnecessary exposure to the broad spectrum antibiotics. Now, diagnostic pitfalls: treating the colonization as infection. Positive culture does not mean the patient has infection. Poor quality of the sputum, delayed antibiotics used in septic shock, missing aspiration pneumonia. So always dwell more on the history, whether the patient is having vomiting, their history of seizures, stroke, the patient is a chronic alcoholic, missing fungal infection, assuming every infiltrate is VAP. So differential diagnosis should be made from ARDS to pulmonary edema, pulmonary embolism, atelectasis. Over reliance on procalcitonin should not be done, because ICU patients changes every few hours, so daily review is a must. Ignoring local antibiogram and failure to de-escalate the antibiotics. So always build a differential diagnosis of the new infiltrates. That should be done. Antimicrobial stewardship is important. So always discuss the 5 questions. Where was the infection acquired? Whether it was in the community, hospital, or ventilator. Is the patient septic? What can be the likely organisms? Is the patient at risk of MDR? Is there history of prior antibiotics? Is there history of ICU stay, previous cultures? What is the source control? Is there empyema? Is there abscess? Is the catheter is infected? So explain the empirical regimens from CAP to the HAP to VAP and septic shock accordingly. So these are the various drugs. What are the various coverage? And these are the various clinical use, from vancomycin, linezolid to MRSA, and cefepime to pseudomonas, meropenem, ESBL producer to severe MDR infections can be done. There are newer agents: ceftazidime, avibactam, meropenem, varborbactam, cefiderolol, and imipenem, relebactam, that are there in the use. Now, antimicrobial stewardship always asks the core principles or 5 rights. What? Choose the right patient, choose the right drug for the patient, choose the right dose for the patient, choose the right route, and choose the right duration. So explain the checklist. Cultures, daily review should be done. Avoid duplicate, gram-negative coverage. Switch to the targeted therapy and stop unnecessary treatment. So introduce this as a daily ICU habit. Is the infection is being confirmed? Are the culture results available? Can therapy be narrowed? Can IV become oral, or can antibiotics be stopped? When to de-escalate? When cultures identify as susceptible organisms. Stop combination therapy again. So discuss about the, narrowing, shortened duration wherever it is appropriate. Again, preventing resistance to following of the hand hygiene through antimicrobial stewardship, proper use of the device, and appropriate duration. Oxygen therapy and medical ventilation from the device. What are the various flow rates? What is the approximate FiO2 that can be delivered through the device? And what is the best use? Now, what are the goals of the oxygen therapy? You have to correct the hypoxemia. You have to reduce the work of breathing, prevent tissue hypoxia, avoid the oxygen toxicity, because oxygen itself is a drug, and bridge to the definitive respiratory support. So escalation of the respiratory support is important, and maintaining the target SpO2 levels accordingly. Now there is ARDS net principles from tidal volume 6 ml per kg, plateau pressures less than 30 cm H2O, driving pressures less than 15 cm H2O, individualized PEEP. So, There is plateau pressure. So plateau pressure represents the alveolar pressure. A high plateau pressure can lead to alveolar rupture. It can cause barotrauma, pneumothorax. Driving pressure is equal to plateau pressure minus PEEP, and it should, maintain less than 15. And individualize PEEP, because one PEEP does not fit with every patient, because a too low can lead to atelectasis and too high can lead to overdistension, thereby leading to reduced venous return and hypotension. Prone positioning can be given in moderate to severe ARDS, having a PaO2 by FiO2 less than 150. So various recruitment maneuvers, temporary opening of the collapsed alveoli, neuromuscular blockade used for severe ventilator dyssynchrony. Although there is no proven mortality benefit, VV ECMO reserved for refractory hypoxemia despite optimal ventilation and proning of the patients. So always look out for the MAP that should be maintained greater than 65 mm Hg, urine output greater than 0.5 ml per hour, lactate should be in the downward trend, SpO2 between 92 to 96 and PaO2 between 60 to 80 mm of Hg. So Berlin's definition of the ARDS has been categorized into mild, moderate, severe. We have discussed about the lung protective ventilation. Now, when to consider ECMO? The patient is severe ARDS with refractory hypoxemia. There is failure of the optimized ventilation, and early referral to the ECMO center should be done. So ARDS is not simply severe pneumonia. It is diffuse inflammatory lung injury that requires a completely different ventilation strategy. So fluid management in ARDS, again, excess fluid should be, it can worsen the pulmonary edema. It can lead to alveolar flooding, impairment of the gas exchange, increase the ICU length of stay. So follow the ROSE concept. R stands for resuscitation, restore the perfusion, O is optimization, assess the fluid responsiveness. And how you will assess the fluid responsiveness? Through the passive leg raise, through the stroke volume variation, through the pulse pressure variation and IVC assessment. So best bedside reversible auto bolus. Stroke volume variation requires controlled ventilation. Pulse pressure variation useful in selected ventilated patients, and bedside echo is excellent for individualized treatment. So early septic shock, initial resuscitation with balanced use of the crystalloids, frequent reassessment, avoid positive fluid balance and conservative fluid strategy, and active de-resuscitation if diuretics and CRRT is being indicated, that should be done. So ICU respiratory catastrophe is think beyond pneumonia. Not every deteriorating ICU patient has worsening pneumonia. Think of the massive hemoptysis, protect the airway. Pulmonary embolism, the patient develops sudden hypoxemia, hypotension, RV dysfunction, diffuse alveolar hemorrhage. If there are, think of the vasculitis, autoimmune disease, tension pneumothorax, if there is absent breath sounds, high airway pressure, hypotension, mucus plugging, sudden lobar collapse, progressive ARDS, so escalation, proning, neuromuscular blockade. So accordingly, these are the immediate actions which should be performed, but always remember the red flag signs: sudden deterioration of the patients, unexplained hypotension, there is drop in the hemoglobin levels, rising ventilator pressures and sudden RV dysfunction. ICU mistakes, there are various diagnostic mistakes, treatment mistakes and ventilation mistakes. Again, this we have discussed: treat colonization as infection, delayed antibiotics in the septic shocks, high tidal volume ventilation, delayed intubation if there is NIV failure, excessive of the sedation and ignoring ventilator waveforms. So what is the golden rule of the respiratory storm management? Recognize deterioration early, never delay antibiotics in septic shock, obtain appropriate microbiological samples, differentiate colonization from infection, use lung protective ventilation, prone positioning early in ARDS, avoid fluid overload, review antibiotics every 48 to 72 hours, and prevent VAP rather than treating it, and reassess the patients daily. So ICU checklist should be there, because, every patient with pneumonia enters the ICU at the crossroads. So one path leads to recovery through time recognition, evidence-based ventilation, appropriate antimicrobial therapy. The other leads to ARDS, septic shock, ultimately multi-organ failure. So early antibiotic stabilization of the hemodynamic source control and daily review has to be done. Respiratory infections remain the leading infections. Early recognition prevents progression. Follow the evidence-based management and lung protective ventilation and antimicrobial stewardship save lives. And prevention is as important as treatment. So hereby I end my presentation. Thank you very much, everyone.
Very nice, Dr. Ayush. Very nice presentation. I think we are all learning tonight. I will leave the microphone to Dr. Alauddin Ghanem and the Professor Hibatullah Asal for moderating the session for 10 minutes, trying to answer the questions.
Thanks, Dr. Ayush, for this comprehensive, detailed presentation. I thought really how you can accommodate this huge subject in one setting, but really you did. And that's why it was good to have a mentally refreshing and challenging break with Dr. Shireen with this nice presentation to able to digest this heavy meal given by you. We're just waiting for the questions through the Q&A. We have one question. Kindly, I may refer for Prof. Amr because actually it's not mainly related to our subject, but he ready to answer it. And the question about an ICU patient who is critically ill with overwhelming sepsis, what is the role of dialysis in managing such patient?
Okay, thank you so much, Dr. Ala, and for the person who raised this question. So I think the question is about extracorporeal therapies, not only about dialysis, because patient with different kind of sepsis, septic shock, acute inflammatory status, acute hyperinflammation and cytokine storm syndrome, they might benefit from cytokine removal and endotoxin removal by different extracorporeal therapies. The Surviving Sepsis Campaign guidelines that was revised, updated, and published in March 2026 emphasize about the use of extracorporeal therapies in different kind of sepsis only in selected patients, only in refractory cases with refractory septic shock, severe hyperinflammation, organ dysfunction, major or multiple organ dysfunction, when conventional therapies are insufficient, when we fail the conventional therapies. But to be honest, what we do in real life, so there is no FDA approval to put the patient on CRRT or to do extracorporeal therapy just to remove the cytokines. You need also to remember that these cytokines are primarily adaptive. So our body is trying to adapt and compensate and try to increase the cytokines to overcome the infection. But sometimes we cross from adaptive to maladaptive. This is number one. Number two is there is pro-inflammatory and anti-inflammatory cytokines. And this device, auxiliary filter, for example, with the CRRT, they don't differentiate. They don't remove only the pro-inflammatory and they don't keep the, anti-inflammatory mediator. So they remove everything. So far, there is no FDA approval to do it, for cytokine removal or endotoxin removal. But we can do, usually this patient will have some kind of kidney dysfunction. So we can start CRT early. We can start heme absorption. We can do plasma exchange. There is different kind of, extracorporeal therapies. So our threshold will go down when we have this endotoxemia or cytokine release syndrome, just not only to remove, but also to treat acidosis, hyperkalemia, volume overload, and other indication. But this is not, FDA approved only to remove cytokines or endotoxins, or even CO2 removal also is not indicated, in patient with different kind of hypoxemia or respiratory failure or septic shock, except there is refractory cases. You exhaust all of our weapons, patient in severe refractory organ dysfunction, then you can do everything possible.
I'm not sure, Dr. Amr, if you agree also. It's all the modern medicine now talking about the individual-based medicine and the different phenotypes of sepsis, the four phenotypes. especially putting a high cost in such a filter. Maybe if we start practice really looking for specific phenotype that he will be the best benefit from in treating the cytocatecholamine storm, this is maybe will give really a benefit from using the Oxaris filter and this modality of therapy.
Absolutely. And the other thing is, we know for fact that these filters or this extracorporeal therapies can remove the cytokines. But is this going to translate to improving our patient outcome? Yes,
Yes.
the studies didn't show this. It doesn't improve our patient's outcome until now. This might change if we have a smarter filter just to remove the pro-inflammatory rather than the anti-inflammatory cytokines in the future.
Sure. Dr. Heba, if you want to have questions for Dr. Ayush or Dr. Shireen.
Yes, please. My question first to Dr. Ayush. Thank you so much for this comprehensive updated presentations. There is a point of debate usually we face in our clinical practice is the administration of inhaled antibiotics, especially in multi-drug resistant pathogens such as carbapenem-resistant Enterobacteriaceae, especially Klebsiella. So, what do you think about adding an inhaled antibiotics like inhaled colistin for these patients?
Thank you, Professor Eva, for the very good question. Now, if you look at the international guidelines, basically they do not recommend inhaled antibiotics as the monotherapy. So they are being used in, systemic antimicrobial therapy as an adjunct. So, but again, their role has been in mechanically ventilated patients with severe MDR or XDR, gram-negative pneumonia, where you have a very narrow down of therapeutic options and they are being limited. So the advantages of inhaled therapy include definitely giving a higher drug concentrations, improving the microbial clearance. But again, a lot of studies or current evidence do show that has not consistently demonstrated improvement in much of the mortality or duration of the mechanical ventilation. So if you look at the international guidelines with the IDSA and ATS, yes, nebulized colistin is being there, amikacin and gentamicin are being there, but their role more as a selective adjunctive role rather than as a routine indication for CRE pneumonia has been there. So they should again should be the never be the replacement for the systemic therapy. They should be used more for the adjunctive treatment for MDR or CRE VAP when you have the limited options for IV options available.
I think also it may have a role in patients like with chronic lung disease, like chronic bronchiectasis and cystic fibrosis, where they are colonized by a known pathogen like the Pseudomonas. Actually, the inhaled antibiotics in these patients, according to the guidelines, is recommended on chronic basis. So if this patient experienced a pneumonia or infectious exacerbation, I think this will fit more in these patients, the inhaled therapies. Also, I have another question for you regarding the antifungal treatment. When do you consider adding systemic antifungal without evidence of a true pneumonia for the patient?
Now, again, antifungals should be used basically if you see that the patient is still having fever, maybe for a period of 4 to 5 days, despite with the use of the antibiotics, and especially high risk populations. You look at the patients having malignancies or maybe having treatment with immunosuppressive agents, patients who are diabetic, who are having HIV infections. So again, and maybe the radiological feature suggesting of multiple cavitatory nodules, there is a reverse halo sign or a COVID-19 associated pulmonary aspergillosis. So these are the basic, indications for using an antifungal. So empirical antifungal therapy should be considered basically in high-risk patients with persistent sepsis or progressive organ dysfunction despite appropriate antibacterial therapy.
Excellent. Thank you so much. I have a couple of questions to Dr. Shireen. If you want to ask Dr. Ayush, Professor Ala, before going to Dr. Shireen, do you have questions?
Actually, we have many questions in the Q&A, so maybe you can take a couple of them because there are a lot. Maybe we'll not be able to accommodate them all alive. But Dr. Ayush and Dr. Shireen, they can help us and answer them even in the chat box later. From Mu'tazza, she is asking, what is the role of IVIG in ARDS? Maybe either of the speaker, Dr. Shireen or Dr. Ayush, can answer.
Again, if you look at the current evidence and guideline, can I take up this answer, or Dr. Shirin, are you?
No, sure, Dr. Ayush, you can have the mic.
Okay. So if you look at, again, going with the evidence that do not support the routine use of IVIG and ARDS, but again, randomized control trials and a lot of systemic reviews which has been done that has shown to show a consistent improvement in either mortality or duration of the ICU stay or mechanical ventilation. So there has been, the role of IVIG is still been, it has although immunomodulatory properties, but again, it is not been frequently recommended as a routine therapy for ARDS. But again, it should be reserved for cases, especially with respect to the lot of clinical trials and studies which has been done up till now for, immunodeficiency or even autoimmune diseases rather than just ARDS itself. I think Professor Heba would like to add something to this, or Dr. Ala. What are your thoughts on this?
Yes. Regarding the role of IVIG, there is no solid recommendations to use it. So it will be also a salvage therapy for some selected cases. But I have no clinical, I didn't use it in my clinical practice because even if it's indicated, it's very expensive. So usually in order to use such an expensive medication to such patient, you have to expect some positive results. So usually don't do that.
Yeah, I totally agree. I think if we use IVIG, we'll use it in the primary disease that it causes ARDS. But for
Yeah.
ARDS itself, I think there is no evidence for this.
Mm.
Go ahead, Prof. Heba, if you have questions for Dr. Shireen.
I just want to ask Dr. Shireen about you have mentioned in your questions about the role of quantitative culture by performing a bronchoalveolar lavage for patients with bronchopneumonia. So, when is it indicated to do such a procedure? Is it routinely done for critically ill patient, or you do it on selected basis?
Actually, regarding the quantitative culture or the semi-quantitative cultures in ventilator-associated pneumonias, they are not routinely recommended. However, it is recommended whenever it's feasible to obtain lower respiratory tract cultures before starting antibiotics. Because the microbiologic data, of course, helps guide the de-escalation of antibiotics or the appropriate treatment whenever the empiric treatment is not achieving the good response to the patient. However, we can, there's a non-invasive sampling option and another invasive sampling. The non-invasive sampling with endotracheal aspirate and semi-quantitative cultures, which is the preferred one, as the invasive sampling with BAL or semi-BAL or protected specimen brush with quantitative cultures did not show in any of the studies improved mortality or improved length of hospital or ICU stay. So it's preferred whenever feasible to do non-invasive sampling with
Yes, so we usually do it on selected patient where there is no appropriate response on the prescribed antibiotic or the patient is deteriorating and so on. So usually we go to this bronchoscopy and lavage, but we do not do it on clinical practice. Another problem we also see during influenza outbreaks, because you have talked about our influenza in your questions. During influenza outbreaks, sometimes the PCR is somewhat delayed because of lab issues or it's not available. So actually, if in influenza outbreak, when you suspect a co-infection, the patient is presenting with a fulminant bacterial pneumonia, but sometimes we suspect that this is super infection or co-infection on top of a viral pneumonia, especially in the outbreak. So I was asking about routinely prescribing oseltamivir in such patients without a confirmation with a PCR.
Yes, it's actually recommended in cases of outbreaks or cases of clinical high suspicion of influenza, even if the PCR is not results are not available or it's not feasible to do a PCR. It's actually recommended in HAP or VAP or complicated PAP to add on oseltamivir, even if the PCR results are not available. And even if I have clinical suspicion of influenza pneumonia, such as with high-grade fevers, or if I'm clinically suspecting influenza pneumonia, we can add oseltamivir, and actually it's recommended by the guidelines to add them even after the 48 hours period, as it can improve the outcome even after the 48 hours period.
Okay, excellent. So do you have still more time, Dr. Amr, or because there are some questions in Q&As, maybe we can handle it if we have time or no?
Maybe 2 minutes.
Okay, so do you want to ask the last question, Dr. Ale? There are like four questions.
Yes,
Let's
I will
choose.
pick one because I was planning also to ask
Yes.
Dr. Ayush about this one. So by Murtaza, I think if I pronounce it correctly, once a patient has developed cytokine or respiratory storm, do we really need to use anakinra or tocilizumab?
Yes, I like this question also.
Yes.
This was when I was going to choose.
No,
So
yes.
yes.
So I think immunomodulators should be basically reserved for, carefully group of selected patients based on the evidence-based indications we as of now, rather than solely administering it because you are suspecting a cytokine storm. So treat basically, I think, the clinical discussion or the clinical, I think, over approach should be that, you treat the phenotype, not just going with to the cytokine, because it is not purely autonomic indication for using of the anakinra or tocilizumab.
So we usually used it in selected approved cases, which were SARS-CoV-2, right? This was the approved indication for using such, and also in a special window. It's not routinely indicated for all of these patients in a special window in a special circumstances. Okay.
Yes, definitely. We have seen a lot of controversies.
Amr, if you can have your input also about this one, should we, because this is what I think we should investigate, same like we have in SARS-CoV. I think really we should dig in more in the HLH and cytokine storm, even not with the viral pneumonia, even with the bacterial pneumonia or the sepsis caused by bacterial infection. I believe there is a room to investigate more in this.
Absolutely agree, 100%.
Sure. We don't have any more time, so the closing remarks with Prof. Amr Hussein.
Thank you so much, Dr. Ala, Professor Heba, Dr. Ayush, and Dr. Shireen for this very nice moderation and presentation. And thank you for all of our attendees who stayed with us for more than an hour. And it's a tough topic. So I just want you to mark your calendar, every one of you, for our upcoming webinar. This would be on this month, Monday, July 27. So please, this is very important topic, surviving sepsis campaign and septic shock, and what every physician need to know in the 2026 with the updated information. We have actually 3 senior investigator and authors of this article that was published in March. So we have Professor Mazzino Antonelli from Italy, Professor Haley Prescott from USA, and Professor Emily Bericot from Canada. And they are going to give us the highlights of the updated information, how to treat sepsis according to the surviving sepsis campaign of 2026. This would be again on Monday, July 27 at 8 p.m. Cairo and Mecca time. So please mark your calendar. By next week, you should receive, all of you should receive a certificate of attendance in your email. Hopefully by tomorrow, you'll receive a recording of this webinar on our YouTube. If you are interested to join our Respiratory Critical Care Fellowship or other the World Institute of Critical Care and Emergency Medicine activities or fellowship, please feel free to do. We are closing the door this week, actually, by the end of this week. So you have only 3-4 days to apply to our respiratory critical care if you want, because we have already started the fellowship. So if you want to catch up and if you want to join, we are going to close the door by the end of this week. And with that, I wish happy afternoon, happy evening, happy night for all of you, wherever you are.
Thank you so much.
Thank you.
Thank you.
Thank you so much, everyone. Yeah.
Mhm.
Thank you.